Welcome to The Explainer. Today, we're diving deep into a really critical topic: antimicrobial prophylaxis for key urological procedures. In our world of growing resistance, this isn't just about ticking a box anymore. It's a high-stakes game of strategy, all aimed at stopping infections before they start, while, and this is crucial, protecting the antibiotics we still have left. I want you to think about this statement for a moment. It really gets to the heart of the matter, doesn't it? It captures this constant tug-of-war we're in. We have to balance what's best for our individual patient right now against the long-term threat of creating superbugs. It means the smartest, most strategic choice is often to hold back.
So, let's get our terms straight. What exactly is antimicrobial prophylaxis? Well, it's a preemptive strike. The whole goal is to get the right amount of drug into the right tissue before the first incision is ever made. We're predicting the enemy, so to speak. And it's so important to remember this isn't treatment. Prophylaxis is all about prevention, using the absolute minimum exposure needed to get the job done.
All right, here's our game plan. We'll kick things off with the core principle behind all of this. Then we'll walk through some key scenarios, catheter removal, TURPs, and so on. We'll look at prostate biopsies, which is a great tale of two approaches, and then wrap it all up with the guiding rules of stewardship. Okay, so let's start with that big idea, the prophylactic principle. At its core, every single recommendation we're about to talk about comes down to a risk-benefit analysis. We're constantly weighing the odds of an infection against the damage we might be doing to our antibiotic arsenal. Let's see how this plays out in the real world.
Our first clinical scenario, bladder catheter removal, is a perfect case study. It really shows how we've moved away from a one-size-fits-all approach to something much smarter and more selective based on risk.
And right away, you see this huge difference. For most adults, taking out a catheter is no big deal. We don't recommend prophylaxis. Any bacteria that get into the bloodstream are usually cleared out pretty quickly. But the story completely changes for kids who have underlying structural problems, like vesicoureteral reflux. For them, the risk of a serious ascending infection, urosepsis, is much higher, so prophylaxis becomes the standard of care.
Now let's dig into those details. You can see the specific situations right here. For that high-risk pediatric case, it's amoxicillin/clavulanic acid for 24 hours. For adults, things get interesting if there's bladder residue or other voiding issues. Ideally, we want a culture to guide our choice. But if you don't have one, a 3-day course of oral nitrofurantoin is a very solid empiric choice.
All right, on to our next category, transurethral resections. Now, there's a non-negotiable foundational rule here. If the patient has a pre-existing UTI, you have to treat it and get rid of it before the procedure. What we're talking about today is purely prophylaxis, preventing an infection, not treating one that's already raging.
So, when do we pull the trigger on prophylaxis for these procedures? It really comes down to these risk factors. For a TURB, if you see a large tumor, multiple tumors, or necrotic one, that's a red flag. For either procedure, if the field is already contaminated, say from an indwelling catheter, that's a clear signal to add. And if you're flying blind without a culture, a single IV dose of cefuroxime is the go-to.
Now let's broaden our view just a bit to some other common endoscopic and percutaneous procedures. The core idea of assessing risk is the same, but you'll see the actual drug regimens have to be tailored to the specific surgery.
So for a URS or PNL, a single dose of a second-gen cephalosporin or a fluoroquinolone usually does the trick. But look at this. For transvaginal surgery, like a TVT sling, the game changes. We have to add metronidazole to the cefuroxime. Why? Because the vaginal vault has a different set of bugs, and we need to cover our bases against anaerobes. It's a perfect example of tailoring the drug to the anticipated pathogens. And you can see even cystoscopy guidelines are starting to evolve.
Okay, now we arrive at a really critical comparison in urology, the prostate biopsy. The route you take, transrectal versus transperineal, changes absolutely everything about your infection risk and your prophylactic strategy. And the difference couldn't be more stark. It is absolutely black and white. For a transrectal biopsy, prophylaxis is mandatory. You have to do it. You're passing a needle through the rectum, a place loaded with bacteria. The risk is just too high. In complete contrast, the transperineal approach goes through clean skin, completely bypassing that risk. So generally, no antibiotics are needed. It just goes to show how the mechanics of the procedure dictate everything. So for that required transrectal prophylaxis, the standard has long been a single dose of a fluoroquinolone. But, and this is a big but, with resistance to fluoroquinolones on the rise, you have to have a backup plan. If you know there's resistance from recent cultures, cotrimoxazole is your alternative. This is where knowing your local resistance data isn't just a good idea, it's essential.
So we've walked through all these specific examples. Now we can pull it all together into the universal rules of antimicrobial stewardship that should guide every single one of these decisions. You know, it's not just what drug you give, it's when you give it. Timing is everything. You've got to hit that peak drug concentration in the tissue right at the moment of incision. That means giving the dose within that 60-minute pre-op window. And you have to think about what happens during the surgery. If it's a long one, over 4 hours, or if there's significant blood loss, you likely need to redose to keep those drug levels effective.
These rules are really our strategic playbook. We target the usual suspects, right? S. aureus from the skin and gram-negatives like Enterobacterales. A key principle of stewardship is this. Try not to use your big guns, the drugs you rely on for serious infections, for prevention. Save them. Then you tailor the plan. Add anaerobic coverage if you're near the gut, and always adjust for things like surgery time, blood loss, and of course, the patient's age.
So, we'll end with this challenge for you to think about. The guidelines we've talked about today aren't set in stone. They're just a snapshot in time in this ongoing fight against microbial evolution. The real job for all of us is to take these principles, combine them with our local resistance data, and constantly refine our own strategies with an absolute commitment to stewardship. Thank you for watching.